afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you're able to join us virtually today for the next webinar in our virtual webinar series. Most of you are likely familiar with our risk management consultation service, the Advocate 800 program. It's one of the many benefits our policyholders receive through the Trust. 3 of our advocates are with us today, Drs. Daniel Taub, Julie Jacobs, and Liesl Bryant. I hope everyone learns a lot over the next hour. There are some really hot topics we're covering today, so get ready. Please join me in welcoming our esteemed presenters.
Thanks so much, Jana. Yes, we do have some hot topics to cover for sure. So we're going to dive right in because I already see some folks posting in the Q&A, which is perfect. As usual, we have a couple questions we're going to start with, some of the questions we've already been getting. And so Dan, I'm going to start with you with the first one. And we've been getting lots of questions about vaccines, as you know. So the question is, I am now fully vaccinated and wanting to return to in-person services. Can I, as the clinician, require vaccinations for all in-person clients? Can I also have them show me documentation to that effect? So showing documentation of having been vaccinated.
Mm-hmm. Sure. Yeah. Well, good question coming up a lot, Liesl. As you know, we're hearing this in our calls a lot. And just to, kind of as a threshold, because this is a health and safety issue, there are good ethical and public health justifications for saying you're only going to see somebody in person if they're vaccinated, for requiring it, and for setting policies. And part of the reason that that is acceptable is that if the person either doesn't meet the criteria, chooses or can't get a vaccine, for example, for medical reasons, you have the ongoing alternative of telehealth. So it is generally permitted, and there are some exceptions. Both, first, make sure you check with your particular state. I am not aware at this point of any states prohibiting professionals from requiring vaccinations, but that may have emerged literally as recently as the past week for some states. It may never. So it's important to check with your own state, look on the governor's page, the State Department of Public Health, for example, and see what their criteria are. Do they allow it? And oftentimes one can't find it, if at all. Still, that is, that you can find the criteria, but you can't find any statement about can you require vaccines. So that's one piece that's an exception to the general rule. Also, and you might want to contact your local state psychological association in terms of whether there are state prohibitions on requiring vaccination. In order to, though, facilitate folks getting the services they need, while you can set that kind of policy and you can keep it, it's important to document your justification. And it's important as well to consider some exceptions to that policy. If, for example, if the patient has a high need and has little or no access to technology, such that they'd be denied care that's needed, then it's going to be more problematic to say they can't come in person. Also, keep in mind access issues here, both as I already referred to, high need, but also technology, as well as access issues for members of traditionally marginalized communities who may not have as easy access or quick access to vaccination, or may have a well-earned distrust of the healthcare system and vaccines in general. So those are all factors to consider in creating exceptions. Now, many states have been and will likely continue to follow the CDC lead. So even when we're meeting right now in person with somebody who is vaccinated, there's still a requirement in place, and I may be stealing a little bit of your thunder there, Julie, but requirement in place for personal protective equipment, social distancing, etc. But it's likely that as progress is made, and as we hope, all of us hope, the progress gets made very quickly, that the CDC will maybe a little bit later than we hope, but fairly soon be changing its guidance. So you have to keep aware of the guidance that's being posted and abide by it. Now, there are a few other dimensions here that I'd like to mention about posting for vaccinations. Very important too, not only the criteria around clients and protecting people on your staff, but for each one of us as providers, we should be careful about putting ourselves in unsafe situations. Our own health, your own health is important. One of the sub-questions that comes up here is, if we are going to return safely to the office and require vaccinations, should we put it as a posting on the office wall, put it in informed consent? Not a bad idea to post it, but it's a very good risk management technique and ethically appropriate and often clinically appropriate to actually have it be part of an informed consent, individualized conversation with your patients and clients. And also to be sure to have trained your staff, have providers who share office space with you come to an agreement about using the same kind of hygiene and decontamination procedures and so forth. One of the other questions that has come up is whether we're required to see a high need person if they're a current client, if until they could be referred in person. And if you can continue with telehealth, then no harm, no foul, okay? You may refer. So that's the easiest situation. The more complex situation is when you have a patient or client who's decompensating and they can't be maintained remotely. In that case, with all of the proper PPEs and informed consent, you can see them in person, but you would probably go through a usual process of transferring their care in an appropriate fashion. And then the last related sub-question, Liesl, to this one is, what about our staff? What if an office manager, for example, doesn't have a valid medical reason and doesn't want to get vaccinated? Generally speaking, and this is at a federal level, states will vary somewhat, but generally speaking, under ADA and the EEOC related laws and rules, employers are permitted to require compliance with work safety policies and health policies. So in general, the answer is yes, you can set that kind of criteria, putting aside for the moment that there may be some state variation here, as long as we do not ask disability-related questions. So you can require documentation of being vaccinated. You may want to warn, if you employ staff or other therapists, that employees not provide any medical information. They can simply have a note from their physician, for example, or if they have a bona fide religious belief, that they could simply only give the information about the medical or the fact that they are not allowed to be vaccinated or it's medically contraindicated. Okay. There are also, there are ADA exceptions to the general rule of making accommodations, and those actually fall squarely, one of them within the health and safety dimension, and exceptions to the exceptions, I seem to be talking a lot about those today, are that with sincerely held religious beliefs, that would be something that we would need to honor. Okay.
Yeah, thank you, Dan. I think this issue is more complex than it looks at just first glance. Julie, do you want to add anything?
I just want to echo, I really appreciate Dan talking about having an informed consent conversation, because I think we get tied up on the fact that the informed consent form is the important piece, and things are changing so much at this point that it may be impossible to keep your informed consent form completely up to date with every policy and everything that you're doing. So if you're having a question of vaccination and you want to talk to your patient about it, you don't necessarily have to update your entire form. Have a conversation, document that conversation, and that's still considered part of the informed consent process. It's not just a piece of paper. But otherwise, there's so much information related to this. I think that was as encapsulated as it could possibly be at this point.
Yeah. And what I like about that too, that both of you have touched on, if you're having that informed consent conversation, that also allows for sort of case-by-case decision-making, which is really, I think, what is still needed right now. It's not, I don't think we're quite to where we can do just some blanket rule, one size fits all. And so if you're having those conversations, that, you can document that, you can, and I think that also helps clients understand where you're coming from too. So,
and that makes me think of something else real quickly we didn't even talk about is minors, right? I mean, kids can't get the vaccine yet.
Right.
And so if you have a blanket policy that everyone must be vaccinated, then you're not going to be able to see your minors. So you might want to make some exceptions for that and consider that as well.
Well, and in that regard, I even wonder, because Dan, you commented, right, there's so many exceptions. In some ways, maybe it makes sense to say, look, we have a preference for vaccines, but not a mandate, because if you mandate it, then you're probably going to end up doing a lot of exception, looking at a lot of exceptions or things like that. And as Dan said, there's some individuals who may not have access to the vaccine or might have fears related, very sort of legitimate, understandable issues that we'd want to address with them, not in a mandatory forcing sort of way, but in a, the same way we address everything with our clients. And so, that's another thing to keep in mind as well, I think.
Mm-hmm. Yeah, just a quick follow-up with that, Liesl. I think, and both you and Julie referred to this, I think this has to do with also who your client population is, who your patient population is. Because if you're working primarily with adults who are, in a university town, it may not be a big issue to require it. But if you're working with children or you're working with traditionally marginalized communities, it may be hard to actually have this kind of policy and have it be fair to the people you're working with. And so I think it also depends very much on the people with whom you're working.
Mm-hmm. No, I agree. So as usual, lots of complexities for us to work through, given where we are and also what states we're in and what our municipalities are saying, because it is really varying. I did just see, as you were talking, someone put a note that in Florida, the governor just passed a rule saying that when you ask someone whether they're vaccinated, there's a fine of $5,000. So I have not heard that. Sounds like you guys haven't either.
Yeah, this is the first I've heard of it today, but I have to say, how come I'm not surprised? Yeah. I think there's a variety of approaches and beliefs around this. And that's why being attentive to your own state rules and the fact that they're evolving so quickly, right? That if it was today or yesterday, it's one of the pieces too that, and I didn't mention this before, one of the pieces too, that it may be important, particularly for larger practices or agencies to consult with local counsel, maybe even sometimes for the small practice or private practitioner about, is there any prohibition here? Because they can be tough to find, and asking somebody whether they're vaccinated and then having a fine really, of course, changes the nature of what one can do. In Florida, I wouldn't be saying the same thing, having known that, as I'm saying generally and throughout the United States, right?
Right. Yeah, and I think one more, and then we really will go on, but one more thing to keep in mind, I think, too, is that although, of course, the science is pretty good in terms of thus far for general effectiveness of vaccines, as best we can tell, there is still some unknown about, does it, so yes, it might keep us safe from getting sick, but does it keep us from spreading the disease? We don't know. So there are still unknowns, and it's not 100%. I know I talked with one colleague a couple of weeks ago who was hoping to get everyone in her office vaccinated and sort of market that, saying, hey, we're 100% vaccinated, therefore safe. And that message, I think we have to be a little cautious just because we don't know all the science. But okay, so we are going to move on for time's sake. So Julie, I will come to you with another related question. Has the CDC said that it's okay to go without masks if all individuals are vaccinated? And if so, what if my state still has a mask mandate? And I'll quickly add, you don't necessarily have to add, but I've also heard now where states are forbidding mask mandates by practitioners. So we are seeing all across the board.
Yeah,
Julie?
yeah. I mean, these are so complex for so many reasons. First, as Dan already alluded to, the CDC guidance changes all the time. And it changes based on new information and new data and new research. So what is true today may not be true tomorrow. I think there was a lot of confusion when the CDC put out some guidance in early April, talking about the fact that fully vaccinated people can meet in private settings without masks. But the key there was private settings. And they actually have different set of guidance for healthcare settings. So the CDC will put out different information for different settings. That's very typical. And so it says specifically on that April 2nd guidance that it is recommendations apply to non-healthcare settings. And then they have a separate set of guidance that was updated on April 27th. I checked it this morning. It hasn't changed yet. Specific to healthcare settings, and it says specifically that you are to continue to use what they call universal source control measures, which includes cloth masks for everyone indoors, even if they are fully vaccinated. Okay, so just like you said, Lisa, a moment ago, vaccines are not 100%. There are a lot of unknowns. There are people who are still getting sick. There are people who are still transmitting. There are variants of COVID out there, so we can't assume that we're safe because we have been vaccinated. We are still recommending wearing masks indoors and engaging in social distancing until you hear otherwise from the CDC or from your state. And this is where it can get really tricky, right? The CDC has guidance and then your state issues something that is contrary to that. That's where you have to make an individual decision as a provider as to what you're going to do. I mean, you have to, at a minimum, do what they are requiring. But if you have a state that says there's no mask mandate allowed, that doesn't mean you can't have a policy that you will have masks or offer an alternative, and that you can do telehealth if someone's not willing to wear a mask. So at this point, masks indoors, even if fully vaccinated, until we hear otherwise, is the more conservative, risk-managed approach. So I think that's the place we're going to come from for now, and it could change next week. Also, just because the guidance changes doesn't mean you must change your policy. If your risk factors are high and if you don't feel comfortable, you are allowed to make your own rules and your own determinations, as long as they're not discriminatory or problematic in some other way. So it's a long answer to say, yes, keep wearing masks even if you're vaccinated in a healthcare setting, and then more to come as they update the guidance and learn more.
Right. No, that's great. Thank you, Julie. Dan, anything you want to add to that?
Yeah, just to emphasize a couple of things, Julie, that you said that I think are really important. The guidance is the minimum, not the maximum. And so there is at least some freedom to gear up or even to stay doing remote services if the clinician is not comfortable with doing in person, and of course, appropriate clientele, right? Appropriate patients and clients. And also the other thing is that, you were mentioning and talking about, I mean, just to hear about the states forbidding mask mandates, like Florida, for example, I think it warrants being cautious about violating those, but thinking it through and talking about it and kind of weighing pros and cons. If the state says no mask mandates, are they saying no telehealth mandates? Because if you could just continue with telehealth, you don't have to encounter the problem, right? And so this is but it's going to depend on the particular set of clients, the particular practitioner, and the particular state.
Yeah, and I do want to just underscore something too, Julie. You were clear, because I see some misinformation in the Q&A where folks have said that you don't need a mask if you're both vaccinated. That's actually not accurate. And Julie, you did explain that it has to do with your setting. And in a healthcare setting, you still do need it. If you're outdoors, it's different. If you're in your private home, it's different. But I think it is important, that we go right to the sources these days. And as you said, Julie and Dan both, right, things are changing so fast. I too checked the CDC guidelines just this morning, right? Because it changes. So definitely go to the source. If you have questions too about this, or if you're stuck in one of those really difficult situations where there's a conflict between the CDC and your state or your municipality, there are some municipalities who have different rules than the state has even. So this is complex, and we would recommend, if you're stuck or if you're not sure what to do, call us, right? That's where you should do a consultation, and you want to be, as we say so often, documenting what your rationale is and why you're making those decisions. So just some additional comments there. Okay, Dan, we're going to come back to you, staying on sort of how things are changing, right?
Yeah.
Can you tell us a little bit about where things stand regarding some of those restrictions that got loosened related to telehealth? So for instance, the Medicare telemedicine waiver for telephone-only sessions, HIPAA enforcement discretion for non-compliant video chat, the COVID waivers for cross-jurisdictional teletherapy, things like that.
Sure. So we'll start with the first one, Lisa, about the telemedicine waiver for Medicare telemedicine waiver for telephone, and where that is now is it's going to continue through the end of the public health emergency. And just as a reminder, most of you probably know, but the federal government makes its judgment every 3 months about whether to extend, and they have most recently extended it up to another 3 months. And there is some indication from the Department of Health and Human Services secretary in a press conference about a month ago that they were expecting it to go for about the rest of this year. So can't promise it. You know, we've said it a lot. It's a moving target. But until the public health emergency is over, the telephone waiver is in place. At that point, its fate will lie with Congress. And there are pros and cons. On the one hand, there's been a significant increase in the reach of services and the accessibility of services, which was the whole point of expanding under Medicare, particularly for patients who have had very little access to or familiarity with or comfort with the technology, but can use a phone because phones are pretty much universal. It's a very remarkable kind of expansion. And while there is some literature suggesting that pretty strongly that traditionally marginalized communities in terms of the expansion of telehealth in the past year have again struggled with access. Very interesting, albeit anecdotal information. I have a colleague who works in a federally qualified health center, and she said that what they've seen is that contrary to that research, they've seen a huge increase in the use of telephone for therapy and much more access to services. So that's a very, very important pro. The cons, however, are that fraud allegations have gone through the roof. And it's not only are there going to be, as a result, more frequent and more intensive audits but the Office of Civil Rights for DHHS and the Centers for Medicare and Medicaid will probably be even less forgiving than normal. So while on one hand, for many patients it helps, you know, it may cause some difficulty in terms of whether the systems and even the federal government is going to say, okay, in the long term. One other piece, and this is a little bit less important because you can always have options, but for many patients, it's been really a boon. But for some, like video chat therapy, phone therapy doesn't suit very well. And some of you have had that experience. So other options would be important, including things like in-person if possible. Around the cross-jurisdictional payments and extensions by Medicare, same idea. They're going to be going on. They're going to be continuous until the declared public health emergency ends. And also, Congress will decide, and the pros and cons are similar. Though for now, we can continue to provide the care and be reimbursed by Medicare without the previous jurisdictional and geographical limitations, putting aside for the moment state law limitations, which I'll get to shortly. Okay, and you know the private insurance companies typically follow Medicare. So if Medicare after the public health emergency is over continues with expanded coverage, maybe private healthcare insurance will follow. But if Medicare retrenches to the old system, and I think there'll be some compromise, that would be my best prediction, even though it's hard to know, you know, some less expansive version, I wouldn't be surprised if private insurance companies did the same. And in fact, I've seen some indications from at least a couple of colleagues, but not that many, surprisingly, saying that the insurance companies were worried, I should say, that the insurance companies were not going to pay for cross-jurisdictional services because they have spent such an inordinate amount of money in the past year. So we'll have to see, right? Now, this is related to the last point, Liesl, in the question, which is, you know, the relaxation of cross-jurisdictional practice rules vis-a-vis licensure for many states. You know, what's going to happen after COVID? And I have to tell you that I think for the most part, those rules are going to return to their set point prior to COVID, by which I mean they're going to go back to the more conservative approach of needing to be licensed or fitting into temporary licensure requirements in a particular state or states, with one major exception, and that is that SIPAC states, as many of you know, if you're in a SIPAC state or your state is considering becoming a member of SIPAC, that as of July of this year, 2021, at least 21 states will be SIPAC members. It is probably the case that we'll be seeing more, closer to half or even more than half of the states in the United States by the end of this calendar year, because there are some additional 8 or 9 states that are considering legislation right now. If you're in a SIPAC state, I think what COVID has done, it has been a remarkable boon to SIPAC, and that we're going to see a continued expansion for a while. Even in my state, California, the state is at least reconsidering the idea that they might talk about SIPAC. There are a lot of pros and cons for our state, but 6 years ago, the Board of Psychology flatly refused to consider it. They said, no, no good. And their working committee had made that recommendation. And then the last piece is the question about the HIPAA relaxation of enforcement. It was actually called an enforcement discretion, and it was issued in March, I think it was the 17th, March 17th, 2020, where they said we could use non-compliant video chat platforms. Of course, the purpose here was to expand the accessibility of services. And given the enormous expansion in the past year, by one study, over 4,300% increase nationally in video chat healthcare services for ambulatory care. So quite astounding increase. The purpose, but there's some fine print, and there's also a couple of caveats, as always. If you look at the fine print of the actual enforcement discretion that was published by the Department of Health and Human Services, they reserved the right to nonetheless engage in enforcement against clinicians if there was a licensing board complaint, for example, that we violated privacy, confidentiality, if it was sustained against us, or there was a sustained ethics complaint to a professional organization, that they still reserved the right to enforce. As yet, I haven't heard of any such enforcement. And, you know, we're probably getting at least, I hope, 2/3, maybe halfway through this ordeal. And they may enforce at a later time, but right now it doesn't seem likely. I do think that the Department of Health and Human Services will go back to their old or previous, it's not that old, standard of requiring a business associates agreement unless HIPAA is overhauled. And there is some real push to overhaul HIPAA legislatively, also, you know, some push from administration as well. One other thing, Lisa, before I stop, please be aware that this enforcement discretion is limited only to the use of non-HIPAA compliant video chat platforms. It does not apply to other dimensions of HIPAA. So we are required to maintain HIPAA compliance everywhere else. And sometimes folks have said, well, isn't HIPAA like suspended for the duration of COVID? And that's not been the case, just this very narrow exception.
Right. Just that narrow exception, and just by the OCR, Office of Civil Rights, not by licensing boards or insurance companies or those kinds of things.
That's right.
Yes.
Yeah.
Thank you for that. That was very comprehensive. I will just add, and then Julie, I'm going to probably, unless you have something you want to jump in on, I'm going to jump to your next question for time's sake, because I'm noticing our time. But I do think Florida is the other state where if you've registered as the out-of-health teleprovider, I think that will continue on past the pandemic, right? So that's SIPAC and if you're a registered provider in Florida, those are the two that will likely, will continue post-pandemic. Okay, so thank you, Dan. That was a lot that you covered. Julie, last question to you, and I suspect this is going to be a big one too, and then we're going to turn to the many questions we have piling up. What is the open notes rule, and how do I know if I'm required to comply with it?
Easy, just kidding.
Just a little quick question.
I mean, I'm going to preface this. I'm going to try to keep this as brief as possible, which will be tricky. And I'm going to preface it by saying this is a very complex regulation. It's new. There are a lot of unanswered questions. It's 300 plus pages of single-spaced small font. Very few people have had a chance to read it and understand it completely. So we're going to take a fairly conservative approach in how we talk about it today. And this information will probably change too. I think that's the theme for today, is that what we know today may well and is likely to change at some point. Just to sort of clarify terms, when we talk about open notes, we're actually talking about the information blocking provisions that are contained in some regulations that were just drafted as part of a law that was signed in 2016, the 21st Century Cures Act. So it talks about, it prohibits information blocking. It defines information blocking as a practice by a provider that's likely to interfere with access, exchange, or use of EHI, electronic health information, by a patient, okay? So what is EHI? It's very similar to PHI. It's just an electronic version, right? So if you understand the HIPAA definition of PHI, this is essentially electronic PHI. Similarly to HIPAA, it excludes psychotherapy notes. It excludes things compiled in reasonable expectation of a lawsuit or some sort of judicial or administrative proceeding. These information blocking provisions apply to healthcare providers, but they are mostly related to this health IT that's ONC certified, okay? So these are health IT, electronic health record systems that are interoperable, that are able to talk to each other. So there's certain data sets that are collected and they're able to communicate with one another. And I think a lot of us are familiar with this in our general healthcare, right? Medical practices. You know, I moved from one practice to another. They were able to get all my Kaiser notes because it's an interoperable system. So that's the kind of system they're talking about. And these regulations apply to those systems. So there's an argument out there saying that even though it says it applies to all healthcare providers, does it really apply to healthcare providers who don't have an ONC certified system? Some argument says no, some arguments say yes. Again, taking a conservative approach today, and let's sort of assume that yes, it applies, and we'll talk about what that means if you don't have one of those systems. The first thing that it means is you do not have to switch to an ONC certified system today, okay? There's no requirement that you obtain one of those systems. Now, a lot of us use things like Simple Practice or therapy notes. Those are not the same thing. Those are more really practice management systems. They don't talk to each other. And so if you're using therapy notes, you don't have to switch to something new, okay? Similarly, if you have paper notes, you don't have to get an electronic health record system, okay? There may be a trend to go back to paper after this open notes thing becomes more active, because you know it's might be easier. We'll see. But really, the whole idea behind it is, like, much as you can sign on to your medical record and see your lab results through a patient portal, this is going to allow access to more notes, to mental health notes. So patients will be able to access their mental health record by logging onto a patient portal in their living room. That's a very different way to think about things than what we're used to doing as psychologists. Another thing to be aware of is that it appears quite likely that EHR systems are going to be required to upgrade to have this capability in November of 2022, I believe is the date. So if you have an EHR and you're going to continue to use it, it's likely that it's going to have this capability, and you're going to have to be ready to figure out how you're going to comply with these regulations. There are no teeth to it right now for healthcare providers. There are no civil monetary penalties. So if you are found to be engaging in information blocking right now, they're talking about appropriate disincentives that they're developing, but I don't know what that means right now. But today there are no monetary penalties. So if you stumble right now, then it's okay. There's probably not much that's going to happen to you in terms of if you're not able to provide this access in the way that patients want it. Like HIPAA, there are exceptions to patient access under information blocking. I'm going to talk quickly about two of them. One of them is the preventing harm exception, very similar to the HIPAA exception. So if you think it would lead to a substantial risk of physical harm if information is shared, you're able to withhold it, and that's not considered information blocking. And then there's another exception called the infeasibility exception, which basically means there's a real challenge. You're not able, it's infeasible for you to provide the access this way. So if a patient says, I want to access my record through a patient portal, and your system doesn't have that, it's infeasible for you to provide that. And what is required when you're invoking that exception is that you have to actually have a written finding, documentation that you've considered certain factors and why is it infeasible. So some of those factors include things like the type of EHR or EHI that's being requested, the provider's financial, technical, and other resources. So if you don't have the technical resources and the cost to you of complying would be high, then that would potentially allow you to invoke this infeasibility exception, okay? So if you think you're going to invoke that exception, it might be a good idea to create some sort of letter or document that outlines why it's infeasible under the circumstances. This doesn't mean that you can restrict access, okay? It just means that you have to give access the old-fashioned way, which is someone requests their record and then you have 30 days under HIPAA. Some states have a shorter time frame to provide access to that record. And that may mean copying it and handing it to them, or it may mean providing an encrypted email with the PDF of the record. But you still have to do it. So even if it's infeasible to do so through a patient portal, you still have to provide access. So real quickly, what are some of the practical implications for psychologists? Reality is not, and at the very base level, it hasn't changed much. Patients have had the right to access their records for a long time. And this is just making it more instant. So it's more of a mindset shift for us. We are used to being able to have advance warning. A patient requests the record from us. We can have a conversation with them about what that means. Might that harm the therapeutic relationship for you to see this information? Can you answer questions or go over the record with them? And so we kind of lose that buffer zone that I think we're used to having when a patient does request a record. So we're going to have to change our mindset and get used to the idea that patients will soon have instant access to records unless you're keeping a paper record, and figure out how we're going to handle that. And one of the things we need to do, and we've advised this for a very long time, always document with the expectation that the patient's going to see the record. Don't document anything you wouldn't want them to see, or anything in a way that you would be embarrassed or upset if they actually saw it. So that's been our guidance for a long time. Now it becomes more salient because we may not be able to be that buffer between the patient and the record. And then you also want to think about potentially adding something to your informed consent. You know, once this is really up and running in 2022 and more people have this, you can say, you know, although you do have a right to access your record through the patient portal, it's our policy and our preference that we have this conversation together and that we review the information together, and trying to put some expectations on there that might limit the patients wanting to just pop on there and read the record. And the last thing I'll say really quickly is, if you're one of those folks who waits 3 weeks before you write your client notes, you're probably going to have to learn to get a little more timely. I mean, there's no time frame outlined in the regulation that I'm aware of, but if a patient saw you 3 weeks ago and pops on and looks for a note and there's nothing there, that could be problematic, and it's really not best practice. So just kind of getting more used to documenting in a more timely manner and in a way that you're comfortable with your patients seeing. And I know this opens a huge can of worms, but I'm trying to be very brief so that we have more time for Q&A. So that's the not so quick and dirty answer.
Yeah, that was great, Julie. You fit in a ton, but you also hit the highlights, which is perfect. And so hopefully if folks have additional questions, we'll get to them as we go. Dan, did you have something you want to say, or can I jump right into the questions?
Why don't we jump into questions?
Okay, all right. So some of these I think we've touched on pieces, and I'll try to pick out the ones that maybe we haven't. One question is, what are our responsibilities for going back to in-person sessions when our state lifts mitigation requirements, except mask wearing, and when it removes that? So I think the idea here is, and I think Julie, you might have touched on it, but do we have to go back just because our state is lifting mandates, those kinds of things? What's our responsibility there? And Julie, why don't I send that one to you first?
Yeah, I mean, no, you don't have to. What you always want to do is, again, analyze your own comfort level and risk factors. And so there may be some folks out there who aren't going to be comfortable doing in-person sessions for a long time because of their own situation and circumstances. Maybe they are immunocompromised or have a family member who is. And, you know, don't feel forced into doing in-person services. I think it's really important, and I know I've touched on this in prior roundtables, that if you are anxious about it and not comfortable with it, you are not going to be at your best, and you're not going to be emotionally competent to provide services. So don't allow yourself to be pushed into a situation where you have to see people in person because you have a patient who's insisting on it. If you are not safe and you are not comfortable and that's not part of your risk analysis for yourself, offer them an alternative, teletherapy, or offer them a referral to someone who is seeing people in person. So I think it's going to be a long time. I think, you know, we need to continue to consider our own risks based on new information. New variants may come out. I mean, this could become worse before it gets better. And so I think that we all need to continue to trust our own instincts and consider our risks, those of our patients, and find a way to accommodate things. There's no one answer. You don't have to be in a room. I know we have long thought you got to be in a room with someone who's never worn masks. This is what we do. Well, look, we've been doing something different for over a year, and people are still getting mental health services and benefiting from them. So we can also be a little less rigid in our thinking and recognize that there are ways to help people that may not be that traditional face-to-face service.
Yeah, that's a great point. And two, I think it's useful to remember, Julie, that there are many right ways to do this, right? There's not just one right way. There's, what all three of us do might end up looking a little different, and same for others. So there's many good options. It's just, we got to figure out which one's best for us and our clientele wherever we are. And a related or similar sort of question, but a twist, and Dan, I'll send this one to you first. Now that many of us are vaccinated, and many, but not all of our clients are, what is our recommendation, the trust recommendation for considering in-person services? Is our prior recommendation to only see clients in person when telehealth is not adequate still wise, or can services be offered on a quote unquote preference basis?
Yeah. So I think it's going to be more of a judgment call now, with many of the caveats, Lisa, that you've already stated, and Julie, about, we don't know that. We know a lot more than we did a little while ago, but the information is still going to be evolving, and the data will be evolving about the vaccinations. But I do want you to remember, one of the things that Julie said a little while ago, folks who are asking the question, the CDC has not said, woohoo, all bets are off for people who are vaccinated. They've said for ambulatory outpatient care, all of the universal precautions need to be used. So that can be a little bit of a damper on meeting with people in person, particularly if you're going to be wearing masks, social distancing, doing all the things that we've been doing prior to the vaccine. And admittedly, you could say, well, that's just a super conservative approach. Yeah, well, we're trying to manage risk for you here. And there are some risks, although they may not be extraordinary, there are some. And so it's worth considering. I think the best, response I can give, Liesl, to that is that, while the CDC is still imposing universal precautions, that people follow them, whether they're vaccinated or not, and that when they change the rules, then one can go and be meeting in person, and they may do so, depending on the emerging data.
Yeah, I agree. And I think part of that last question was, can we just go off of preference alone? And I think preference can be part of the analysis, but it shouldn't be all of it. As both of you have laid out a whole bunch of factors, there's many things to consider. Preference is just one, and may also not be the most important, right? So yeah. Okay, this is a quick one. Can we continue providing phone therapy to Medicare clients? And Dan, I'll send that straight to you because I know you touched on it briefly, but can we do that right?
Yes, and only until the end of the public health emergency. So you've got to continue to be monitoring, which is a horse that we have beaten quite a bit today.
Yes. And I think too, right, I think after the public health emergency, even if the phone only continues, they may go back to requiring at least some in-person sessions for
Exactly. Yeah.
So
and that's for video chat, Liesl. That would be for phone and for video chat that they may. We will see. The law currently, as was put in place right at the beginning of this year, says at the end of the public health emergency, there will be a requirement under Medicare. This is not necessarily private healthcare insurance, but under Medicare, to have an in-person visit with a person. I believe it's got to be once within the past 6 months, but we don't know whether that's going to be continued, that particular standard, or whether it would be amended. We don't know.
Right. And so, as Julie said, the theme of today, things will change. Check back often.
Right.
So, okay, next question. I run a practice with 15 independent contractor therapists. We provide facilities and administrative services to the 15 independent contractors. I'm assuming that if someone sues, they're going to sue everyone, meaning the therapist, the practice, the landlord. Is there any nuance to this because they're independent contractors, or are we liable as well? And Julie, you want to tackle that first?
I will do my best. I mean, there's certainly the potential for some variation based on state law in terms of liability. But, one of the things about independent contractor relationships that can be nice is that it does tend to give you a little bit of a shield from liability for the act of your contractors. But we're talking about a building here. There are a lot of different elements to this. And the best thing I can say is you don't want to be negligent in how you are operating. And part of that includes following the guidance that's out there at a minimum. And that's going to be a big shield for liability. It's going to be very hard for someone to prove that I caught COVID by going into your office, because there's a lot of different potential infection points between my house and your office. And, you know, I didn't just transport there magically. I had to get there somehow and probably had exposure to other people as well. But if your office is operating in a way where there's no safety protocols and no one's wearing masks and no one's sanitizing and you got a packed waiting room, that's going to be problematic. And that's going to potentially, you know, look like you're being negligent in how you're operating and would potentially create net liability. And I hate how often we're saying maybe and potentially, but this is a brave new world, right? These lawsuits haven't happened yet. We're not exactly sure what the outcome is going to be. And so these are untested times. And so it's very hard to predict with any precision. I think we're going to just continue to say, you can't control what your independent contractors do. You can have preferences and policies and you can let them know what you are doing. If you're controlling the building, if you're a landlord, you have more ability to control what goes on in that building. So it really depends on which of those roles you're in. But the bottom line is following those health and safety protocols it's going to be a good way to try to shield you from liability at any of those levels.
Mm-hmm. Right. Yes. Thank you, Julie. That was great. Another question, again, related in some ways, as more and more people get vaccinated and states open up, are you recommending that we continue to use COVID-specific consent forms, like the extra consent, the consent addendums we've been recommending, as well as health and symptom screenings? At what point do those no longer become necessary?
Right.
Dan, you want to jump in on that one?
So, you know, so at least from a risk managed perspective, we are recommending that. We are recommending that you use COVID-informed consent, that you use the universal precautions. And the point at which that will end will likely be when the federal and state guidance changes. And it's hard to know when that's going to happen, but we are recommending it. I actually wanted to, this relates to the previous question, as you pointed out, Lisa, and Julie, I thought you put it really well. You know, if you don't do this stuff, and then it gets much easier for somebody to prove negligence. But even with the difficulties in proving that it's my office that caused the illness, I think what licensing boards in many states, not all, okay, but licensing boards in many states are going to be looking at is, did you follow the CDC guidance? And if you didn't, they don't have to prove that that we caused anybody any harm. They just would be able to engage in an enforcement action.
Mm-hmm. Right. Right, I agree. Okay, for those of us who specialize in children, are you suggesting that we maintain telehealth? Julie?
That's a tough question. I mean, I think it's the same analysis that we've been engaging in. And I know it's tough because we've got kiddos who haven't been seen in person for over a year now. And there's probably a sense that they would benefit from some in-person services. It's going to depend on the individual provider, their risk profile, and their comfort with doing it, and their ability to engage in proper protocols. And it's tougher with kids because they can't get vaccinated yet. And so masks become even more important. And, you know, gosh, doing sand tray, you know, how do you do that socially distanced, and how do you disinfect all the toys? I mean, there are protocols out there. There's actually guidance out there from some of the play therapy associations. So, you know, this is not happening in a vacuum. Nobody has the right answers, but there's a lot of guidance out there. So I suggest, you know, if you are a play therapist, look to the Play Therapy Association and see what kind of information they're putting out there and what kind of guidance they have. But we're taking a conservative approach. And I know this is really unsatisfying also because we're all starting to see the light at the end of the tunnel here. And we're thinking, you know, it's time, but it's not quite time. It's just much closer, and things are changing very slowly. But it would be, you know, it'd be a hell of a thing to get sick now or to get a patient sick now when we're so close to the end because we were rushing and pushing to get ourselves back into in-person services for everybody.
Right. No, great. Okay, another question that we have touched on, but I think it's asked in slightly different ways, so it might help to underscore it. I work in a health setting and a client who is vaccinated does not want to wear a mask. Should I insist that they should? Dan?
Yeah, I think it's wise to insist. We can't physically force people. So we can say, if you're not going to wear a mask, I'll meet with you virtually, right? Even in a healthcare setting. And The other thing is that if it is indeed a healthcare something, like you're embedded, a psychologist embedded in an professional team, there are universal precautions in that kind of healthcare for setting. So the person is saying, I don't want to do what everybody else is required to do. I think you've got some reasonable basis for saying, no, this is what we're required to do here. And this is our policy. Again, this is going to vary by state, but I do think that the healthcare professional, the psychologist in this case, has a basis for saying, well, we'll meet in the alternative fashion through telehealth.
Mm-hmm. Great, thank you. This is a somewhat different topic, but does come up a lot, so I think it's worth raising. Is using insecure or unsecured email or texting considered a HIPAA violation? And given that so many people these days are using email and texting, Julie, do you want to take a step?
I mean, encryption is the gold standard. Encryption gives you a safe harbor if there's a breach. Okay, so that's why we love encrypted email. Or encrypted computers, encrypted everything. If your your laptop gets stolen and it's encrypted, that's not going to be considered a breach because no one can access the information as long as the encryption key isn't written down somewhere on your computer. So, HIPAA, HHS expects you, if you're going to use unsecure communications, to warn clients of the risks of those unsecured communications very clearly, and to have them agree to those risks and opt into those risks. And I think, sometimes I see on informed consents, they just have a paragraph that talks about risks. And then by signing this form, you're agreeing to them. I think it's safer to have a checkbox or an initial or something where someone is explicitly saying, I understand that this is not secure. I understand that it's risky. You don't want me to send clinical information, but I am agreeing to text you about appointments and about other things. So it's best to be as secure as possible. I'm a little old school, texting clients to me is like, oh my gosh, I would never do it. But I also haven't practiced in the last few years. And I know that there's a lot of clients who will text you no matter what, even if you tell them you don't take texts. So you just want to be sure that you've warned them of the risks and they have explicitly opted in with an understanding of what those risks are. But the use of that in and of itself, using a text is not necessarily a HIPAA violation. It's just what happens in the context within which you used that text and whether it's accessed by somebody else.
Yeah.
Right. And then it depends if there's a breach, what you have to do, because if it's secured, you don't have to follow the breach notification rules. Whereas if it's unsecured, then you do have to follow that. So, yeah.
And Lisa, if I can jump in just quickly, I know we're almost done, but the other part of this is that I do think we recommend using encrypted email and text and HIPAA compliant email and text, even though OCR says you can, or DHHS says you can use something else, because state licensing boards and also in the context of lawsuits, you can point to HIPAA allowing it, but if there's a breach, there's still some potential exposure.
Right. Yeah. Right. Yeah, great. Thank you. So, okay, here's a sort of general question about telehealth. This might be our last one. We'll see how quickly we can address it. But now that telehealth has become more, quote, mainstream, what are your thoughts on providing both short-term telehealth services to clients, such as if they're away on vacation, or longer-term services like a teen going away to college? Obviously, if they're out of state, this would depend on rules in my state and the other state. But even if this pans out legally, what might contraindicate doing this? So that's a big question, and I know we can't give specifics, but could you give some sort of general thoughts about how do we think about telehealth now that it is mainstream, but it's not always technically legal depending on what the state laws are and things like that? And Julie, do you want to jump in on that to start?
Yeah, I mean, one thing to know is, telehealth has been around since before COVID. There are guidelines for telepsychology services that are out there. That's sort of the standard of care at this point. It's been developed by the APA and by the trust, and there was some collaboration there. And so making sure that you're meeting the standard of care, making sure that your patient selection is careful, right? Some people are just not going to be appropriate for teletherapy, long-term or short-term. So following those generally accepted standards of the practice as they're being developed. And now I do think telehealth is going to be mainstream. I've heard anecdotally a lot of providers who are moving to telehealth only practices. It's working for them, it's working for their clients. And so certainly there's the interjurisdictional issue. I think we're all on the same page. If it's a temporary relocation and someone's in another state, it's pretty low risk. There's probably more risk in not seeing someone in some situations and sort of abandoning them or harming them versus having a session or two while they're away. But I think telehealth is the way of the future, and I think it's going to continue. We're going to continue to develop these standards of care. You still want to have a informed consent that's specific to that because there are unique aspects of it. That's as quick an answer as I can get, and I'll give Dan a chance to jump in. I mean, this is a huge question. We have entire seminars and workshops on this.
Yeah. Well, this is anecdotal, like everything at this point. But I spoke to a colleague just a few weeks back who said that they asked all of their patients, when would you like to go back in person? And none of them said they wanted to go back in person. They had a 33 or 34 patient load, huge load. So it's going to vary, but there's going to be a lot of preference because of convenience. And the literature seems to suggest that it's comparable for many people, not everybody. There are always exceptions.
Great. Well, thank you both. I see more questions we didn't get to. I'd love to squeeze one in, but I see Jana coming on very quickly here. I know we are out of time technically. So thank you all for the questions. We, of course, will be back in August, as Jana mentioned. We will take more then. And in the meantime, you certainly can check out our website, which has a lot of resources, and we try to address these questions on there, and or call us for consults.